Hello, everyone. When the organizing committee for this meeting reached out to me after I went public with my diagnosis of lung cancer and asked me to give a special talk, I puzzled over what I could say to you. My story isn't any different than anyone else's with a serious disease. Jane, who you just heard from, has had to go through this cancer journey not once, but multiple times. Every person with health issues has had to go through their version of, this isn't some role play, this is actually happening to me. When your life changes suddenly in a way that almost everyone would view as for the worse. A diagnosis of cancer, of any disease, doesn't wait for a quiet period in your life when nothing else is going on. It doesn't wait for when you can fit them into your busy schedule. My 90-year-old dementing mother, shown here, rescued from the isolation of COVID in Edinburgh, had moved in with us at the start of 2022. When she arrived, she was underweight, poorly taking her medicines, vulnerable and grateful. As she got better, unfortunately, paranoid delusions and bitterness emerged as her dominant personality. By April, she was being mean to our children and criticizing my wife regularly. In a moment that I, as her son, could never have orchestrated, one day in the kitchen after her latest tirade, my wife said, "Well, if you don't like it here, why don't you just go home?" Several years later, my wife and I separated for complex reasons, including my cancer diagnosis, but she was magnificent that day. Sharing too much? If we're honest, we all know that life isn't neat or pretty or photogenic. No matter what we show to the neighbors or the media, sometimes it feels like a lurch from one crisis to another, a fall from a tree with multiple bumps off branches on the way down. And then in the midst of all this, in May 2022, a few weeks after my mother, under her own steam, did indeed go back to Edinburgh, I developed an ache in my left shoulder. Not much, just the sort of thing that felt tight, but if you stretched it, it would relax. And then about 2 weeks later, I noticed a noise, a particular noise, when I was breathing out. I knew I needed to check it out. I set up an appointment to see my PCP. They were booked solid, but on Friday, June 10th, 2022, I went to see Dr. Doolan at 8 a.m. I just had some meetings the rest of that day, nothing too much. Dr. Doolan was a good primary care physician. "Let's get you some inhalers," he said, "and then you can come back and see me in a couple of weeks." At the end, I mentioned with a smile that I was a thoracic oncologist, and while I was probably just being professionally paranoid, would it be all right if I had a chest x-ray as well? He smiled back and crinkled his eyes indulgently. "Sure, just walk into radiology and I'll put the order in now." So I left his office, went down to radiology, had a chest x-ray, walked to the next building along and took the elevator up to my office. As I was settling in to answer emails, my phone rang. It was Dr. Doolan. "There's something on your chest x-ray." I put in an order for a stat CT chest. It's scheduled at 2 p.m. As soon as I got off the phone, I pulled up my own chest x-ray on my own office computer. It looked like lung cancer. I don't think I was surprised. I knew the noise I had heard fitted with an obstruction. I called my wife. She was boating with our 2 daughters up in the mountains, and she offered to come back straight away, but I was fine. I'd get the CT, and then we'd talk. I'd never been in a CT before. It was rather fun. I took a picture of my patient ID bracelet. I didn't know what else to do when I was in the waiting room. Afterwards, I pulled my own scans up immediately, long before any report came in, a pattern that I would end up repeating every 90 days for nearly 4 years now. On that first CT scan, there was a right upper lobe mass, ipsilateral nodes, bilateral lung deposits, and bone metastases. I don't remember when I emailed select members of my team, maybe that same Friday, maybe on Saturday after I had my MRI and saw this guy in my brainstem. I told my medical oncologies first, in case coverage was needed. I copied in the pulmonologists and pathologists as I knew I would need a biopsy and molecular analyses. I copied in the radiation oncologists as I knew things would need to be irradiated. I was used to running a professional team, and I relied on that professionalism to keep us all on track. For example, I didn't tell our surgeons because I knew I wasn't an operable candidate, and I also already knew that I wasn't ready to tell the world my diagnosis. There were still unknowns, and we hadn't told our children yet. They were only 10 and 12 at the time. That first evening, I think my wife and I sat on the stoop of our house, outside so the girls couldn't hear us, and discussed a plan. We'd get all the facts, a treatment schedule, and we'd tell them when we had something concrete to say, some hope to focus on. Inevitably, there was a knowledge gap from day one between me, an expert, and my wife, who does not have a medical background. We, the patients and caregivers, live in that world which is largely black and white at first. Death is coming soon and we need to pull the kids from school, or everything is just fine. Hope is possible. You can be the exception. Only we, the clinicians, live most comfortably in the grey, with the likelihood of badness, of goodness, but with no promises of either one happening, and certainly no promises as to when things may occur. A bronchoscopy happened on that Monday with Dara Eisner there to confirm paydo was hit and to get the molecular testing going. A PET on the Tuesday morning revealed no extra surprises, and by Tuesday evening, Dara had identified an exon 19 deletion EGFR mutation. I had received some unused osimertinib back from the spouse of one of my patients who had passed on. They were sitting there in my office. And that evening, 4 days from the first primary care visit, to borrow a phrase from Peter Pan, I started on my awfully big adventure. Given what I've shared, I'd like to expand on the theme of why we are here. While my team moved me through the system quickly, what I took away from it was not that the privilege of you can do this if you're an insider, but rather the realization that it was possible and that part of what I might contribute was to emphasize to others that every patient could be themselves, to present a challenge to deliver the standard of care that they would want for themselves to everyone, every day. I had to find a medical oncologist to lead my care, and I asked Tejas Patil. I trained Tejas, worked with him since he was a resident interested in oncology, and I knew he was ready to take on the job. I knew it wouldn't be a normal doctor-patient relationship. He knew it too. I remember him suggesting initially that we only communicate about my case through the patient portal. To which I replied, "You have the office next to mine." That is not going to happen. I don't direct my care, but I don't deny my knowledge either. What was always a mentorship relationship based along peer-to-peer discussion has continued with one of the issues that we discuss happening to be my own care. Tejas has come to describe himself as Roger Federer's coach, which feels just fine to me. Coming back to leading by example, it was important to me to practice what we had been preaching. We had bought into the idea of minimizing cancer diversity to prolong TKI control, so we added in chemotherapy after the first on-treatment scan, what you would now consider a modified FLAURA2. And then, consistent with these data, the chemotherapy was a bridge to using radiation to ablate everything that was initially identified as a site. This is going to make Jeremy Setnar's debate later rather hard. All of this finished in early January 2023. I decided not to go public with my diagnosis, and the circle of trust remained small. Just osimertinib daily and scans of the body and brain every 90 days. You can ask yourself whether you would have gone public straight away or not. Whatever you decide will be right. People often ask me whether my own diagnosis changed how I care for my patients. I don't think it did in some kind of Hollywood transformation from Dr. Stinker to Dr. Saint. except perhaps a greater appreciation for the existential stress of rolling the radiographic dice every 90 days and seeing if your life is about to head downhill. For some, looking from the outside in, everything looks normal. Scans come, they look okay, you move on. But for many of us, scanxiety is real. For a few days before a scan, all thoughts of the future become clouded. Even plans for dinner the day after the scan make you irritated, acting as if life goes on when you don't know if yours will. It all makes you contemplative and distant. Then every good scan, like an act of violence avoided, feels amazing, and the world looks clearer as the stress shadows recede, but they also leave some cumulative PTSD each time. Perhaps by calling this out and the experience of being a patient, we, the patients who share our experiences with you, are here to keep us all focused on a singular fact. Our trials, our research, our care are not directed to patients, but to people. People with lives that lung cancer has gotten in the way of. Knowing that, it is equally important to embrace the fact that a diagnosis of a terminal disease is not the end of ambition or aspirations or drive in that individual. Although I took great delight in stepping back from some of the more boring roles in my day job, I still took on new ones. Sometime in 2022, I had contacted Onc Live and pitched a rolling podcast digging into the highs and lows of the lives of real people involved with cancer, cancer medicine, and cancer science. Stealing the title from a similar-sounding NPR show, I called it How This Is Building Me, and I interviewed my first guest, Jeremy Setmer from OHSU, in January 2023, about 20 minutes after I hopped off the Linac table for my last brainstem irradiation. I didn't tell Onc Live my diagnosis, nor any of the nearly 50 guests I've had on the show since then. I continue to practice, advise, mentor, research, present, and publish. People with a terminal disease are not just sitting around waiting to die. As we push out survival times, part of why we are here, all of us, is to redefine what it means to live, not just to die with this disease. I wish I could talk to every man and woman who works in the pharmaceutical industry or biotech in oncology and say, you impress me. Your dedication to work within the constraints of a for-profit industry to change the world absolutely for the better has been the force behind so many of yesterday's dreams that are now today's standards of care. But progress in the future will be about more than new drugs. If you imagine what you, as the recipient of these treatments, would most like to know, I would urge you to have two new guiding principles. First, own your toxicity. Don't underplay it. Together, let's find better ways of presenting toxicity in a meaningful way. Meaningful in a way that would allow the user of that drug to plan for their future more accurately. Not just the rate of grade 3 events. What about the time to a given grade, the duration of that grade, its impact on people's lives, whether different management strategies actually work? Here you can see from the original phase 1 study of crizotinib that by presenting toxicity over time, grade 1 and grade 2, you can see when to expect the different side effects to occur. Peripheral edema from the metadimation is both a late onset and cumulative. We have this data. We could do this for every study. The other new guiding principle for the industry is that I would encourage you to embrace something which is simply, if your mum or another loved one was the patient, and she has a choice between your drug and several others, whether we can present efficacy in a different way. Traditionally, we have focused on the chances of something working together with its toxicity. But as the chance of benefit increases, we can flip that script. What if within your trial data set you could define a population with 0% chance of benefit? Wouldn't that be almost as useful as knowing the response rate and PFS in the overall population? Especially when you have alternate treatments to try. While sometimes I know this can be very difficult, in the setting of acquired resistance to target therapy, coming in with a next generation whatever inhibitor when the mechanism resistance is a proven second driver is the example I am thinking of. This is where a next generation drug direct against the same pathway will not work. Look at these waterfall plots. For second-line use of ALK inhibitors, ROS1 inhibitors, if there was tissue to assess on-target mutations, what percentage of cases with, for example, MET amplification as a second driver sit in the red boxes here? It won't cut your market size too much, but if you have this information, then share it. Your mum would appreciate it. I want to say something to the clinicians, the investigators and academics in the audience now, especially those early in their careers. This is a tough time to be a thinker. Reduced funding, increased clinical demands, but know one thing. Your value, the reason you are here, is not just to offer up your patients to pharma and believe they have all the answers already. They don't want that either. Your value to the world and to pharma is to add truth, to add independence. If you were on American Idol or The X Factor, would you rather have Paula Abdul or Simon Cowell giving you feedback? In an ad board or an investigators meeting, most of us would want to hear Cowell's truth, albeit with a little diplomacy. As an academic, you have to approve the presentations and publications of any pharma trial you're involved with. Now, of course, you can sit back and just approve, or you can add value, even if you're the 5th or the 10th author, whatever. Remember, every interaction early in your career is an audition for your next one, whether you think anyone is watching or not. Here's an example. The weight gain with lorlatinib that is described in this slide as not increasing over time. It combines together grade 2 and grade 3 weight gain. So if everyone went from grade 2 to grade 3 over time, potentially increasing from 10% weight gain to 50 or 60% or more, this way of showing the data would not reveal anything as occurring cumulatively. That's where the investigator's voice of truth was needed. If you miss something the first time, do better the next time. You add value. In early 2025, I had oligoprogression. I received focused radiation, and then because the idea that it was really the only site on a microscopic scale seemed unlikely, Tejas and I opted for another round of platinum pemetrexed with the osimertinib, but based on the Mariposa 2 study, we added in amivantamab too. Importantly, I am in no way presenting myself as a summary of everyone's experiences with that drug, but for me, it was very tough. We had planned 4 cycles, but I was done by 3. You tend to miss it in the paper, but the full thing exaggerates nausea, edema, rash, paronychia, constipation, stomatitis, and I had it all. Janssen now suggests a prophylactic steroid shampoo, which I hope will be a step forward. They are probably the best example of a company owning their toxicity and evaluating their management strategies, for which they should be viewed as a role model. But really, it was tough. I decided I couldn't keep my diagnosis secret any longer at this point, partly because I looked different, and what had simply been not volunteering information in the past would start to look a lot more like lying, partly because in the worst of my amivantamab days, when I was completely non-functional, I felt I didn't want to die and miss out on whatever good I could do by coming out publicly with my diagnosis and sharing my dual role as both expert and patient. I worked with one of the cancer center's communication leads to craft the article, and then when it was written, it was just about choosing a date to release it. Do you want to wait until your next scan, she asked me. I thought about it for a second. There's always a next scan. So we sent it out into the ether on September 8th, 2025. I don't entirely know what I expected, but the reaction from so many different groups was wonderful. I had worried what my patients would think, but they were, of course, the most understanding. I'm walking in their shoes, after all. Pharma, academia, and clinical colleagues did exactly what I asked of them. They treated me the same. The cancer got a nod. We could reflect on 3 years of interactions that had gone well. They just didn't know they were dealing with a cancer patient at the time. And then we just moved on. The invitations haven't stopped, but I try and manage expectations or commitments far in the future. For all of you who reached out, whether we had known each other well beforehand or not, just know that your simple act of kindness meant the world to me. I'm going to wrap up now. I had some more progression recently, and I've just started on a new treatment. So thank you for letting me share my journey and my thoughts with you. And thank you for being here, for being you, for developing your company's drugs as if every patient was you or someone you loved, for being advocates and putting a face and a life to every data point, for being clinicians and academics and bringing truth and independence to all your interactions. But overall, thank you for being here to try to make a difference. Thank you.